Foot hyperpronation is one of those functional deficits that contributes to so many of the lower chain and lumbar spine problems that you and I see as chiropractors. That in the same way that hip abductor weakness goes down chain, foot hyperpronation comes up chain. So foot hyperpronation is a component of a complex mechanical arrangement, that the foot has a whole lot of bones. It has 28 bones, it has 33 joints, it has more than 100 muscles, and all of that put together has to function in two very different roles. That the foot has to be a flexible shock absorber, but it also has to be a rigid lever in order to push you off. So think about running through the woods. You want your foot to be very flexible shock absorber. You don't want a hard lever foot falling down on a rock or a root that we've done for the last millions of years. We want to make sure that it's a flexible shock absorber in that process. But then when we want to propel ourselves, we don't want a flexible shock absorber. When we hit a baseball, we don't want a flexible bat, we want a stiff bat. And when we propel ourselves when we're running, we want a stiff lever to do that. Well, the way that the foot transitions from a flexible shock absorber to a stiff lever is the process of pronation. Pronation is not a dirty word. It's a natural process that allows the foot to perform those seemingly incongruent roles. That hyperpronation means a combination of dorsiflexion of the foot, abduction of the ankle, and eversion of the ankle. And that combination allows us then to function in activities of daily living. The normal gait mechanics of contact is we contact with our heel, at least when we're walking, and that contact is in supination. So there's very little pronation, there's a very flexible foot. And then at mid-stance, we start to stretch out the foot, and when we stretch out the foot, what we're doing is we're taking the plantar fascia, we're causing the arch of the foot to come up, and when it comes up, it's going to lock out. Now, if it's not able to lock out and it falls back down, it stays in supination. And that's where the problem, if it's not able to lock out in supination, it falls into pronation. And that's where the problem is if the foot hyperpronates. So when we go from supination to pronation, that should lock out and stop at a certain point. When it doesn't stop, now we have a problem. And so the normal safe range is somewhere between 0 and 8 degrees of pronation. When a patient has more than 8 degrees of pronation, that's hyperpronation here on the left side, and that patient is probably going to have an issue. Not too many patients have a problem on the far right side of excessive supination, but hyperpronation is prevalent throughout society. That when that ankle dives in, one of the things that we're going to see is a medial bowing of the ankle. On the right ankle, you can see as that patient is hyperpronating, we're getting a medial bowing. You can see it at the Achilles tendon. You can see it with the medial malleolus becoming more prominent. And so things are going to get stretched, particularly things on the medial aspect of the ankle, that these tissues, the posterior tibial tendon, the posterior tibial nerve, are going to be stretched. So in this example, we can see that the posterior tibial tendon is coming down behind the tibia, and as it comes behind the medial malleolus, it comes down and it inserts down onto the tarsal bones. That's the piece of duct tape that helps to pull up and hold up the arch. When the foot hyperpronates here, and now there's a bowing of the Achilles tendon, there's the medial malleolus is prominent, that's causing a stretching of this posterior tibial tendon. It's also causing a stretching of this of the posterior tibial nerve. And when the posterior tibial nerve is stretched, it's going to cause numbness and tingling along the course of that nerve, which we'll talk about in just a few minutes as tarsal tunnel syndrome. We know that in the same way that hip abductor weakness at the top can allow a medial bowing of the leg to drop into uncontrolled adduction of the knee, we also know that hyperpronation at the bottom of that chain can cause the same force. That hyperpronation causes the tibia to rotate medially, which puts uncontrolled adduction at the knee, which torques the femur, and then comes up chain as well. So the same thing that's going down chain can come up chain, and most of the time those things are combined with each other, that when we see one, we'll often see the other. But it can be an isolated case. Either way, lots of things are paying a price along the way, not just the knee, but also the hip, and as we talked about earlier, the lumbar spine too. That when the pelvis is thrown into a posterior tilt, we need hyperextension in order to stay upright. And that can start at the feet. We've seen these a number of times. One thing that we haven't talked a lot about is this, and it's pes planus. The difference between hyperpronation and pes planus is that pes planus is just a flat foot all the time. Whether it's weight-bearing walking or not, we're going to see that the arch has fallen. Hyperpronation means that we have a decent arch until we load it. And when we load it, then we get excessive pronation. So that's the difference. A lot of times, pes planus and hyperpronation coexist, that somebody has a degree of a naturally flat foot that then goes away when that patient walks. Some of the tissues that pay a price when that process happens are these: that the plantar fascia is going to be stretched, that anytime there's excessive pronation, we're going to get excessive stretch of the plantar fascia. We're also going to get excessive strain of the talonavicular ligament and the insertion of the posterior tibialis tendon. And as we talked about earlier, we're certainly going to get stretching of the posterior tibialis tendon and the posterior tibial nerve. So this patient will present with an array of problems. The hyperpronation patient can really have any of the diagnoses from down chain all the way up chain. A lot of times plantar fasciitis is the primary presentation, but it can also be Achilles tendinopathy. Remember that down low, we've got the calcaneus, and the Achilles doesn't insert right in the medial of the calcaneus. It inserts, right in the middle. It inserts more medially. So if I'm talking about my right calcaneus right now, my Achilles is inserting a little bit medially. So if my right foot then pronates, you see what happens to the medial aspect of that Achilles tendon. It becomes stretched. And any tissue that we stretch for a prolonged period of time is going to become ischemic and is eventually going to degenerate and then be prone to tearing. So Achilles tendinopathy is certainly one of those problems that's provoked by hyperpronation of the foot. We've talked already about the lower portion of this list, the bad things that happen when that patient's foot go into hyperpronation. So how do we assess this patient? Well, there's a couple of things. We have the hyperpronation cluster. And rather than reading this to you, let's just go through each of them. Number one is, what is the plane of the tibia? That the tibia, as it's pointing straight forward, should come through about the second digit. If that tibia starts to come through the first digit or even comes off the medial aspect of the foot, the plane of the tibia, now we know that there's a possibility of hyperpronation. The other very sophisticated test that we use is this one, called the too many toes sign. That when we stand behind the patient, we should see, as on the right foot, about 2 toes. If we can see more than 2 toes, in the left foot, in fact, we can see all 5 toes, that tells us there's probably hyperpronation. Another clue here is look at the Achilles tendon. That the right Achilles tendon is really nice. It's going straight up and down, and that straight up and down means that there's very little bowing. And on the left Achilles tendon, we can see this acute change here in the shape of that tendon, which is another sign that there may be hyperpronation. Now, one of the things that we've done in our office, we've installed a $250,000 track and a $2,000 high-speed camera to measure that. We call that our parking lot and my iPhone. And so when a patient comes in, we'll have them bring their running shoes and we'll have them simply run down the parking lot. And we can videotape that on the iPhone or any other Android device in slow motion and then play it back, which gives us a much better indication of what are the mechanics of the foot, because a lot of times these conditions are pretty subtle. So when we have this patient on a slow-mo camera, now we can see much better what's happening. We can see that is this patient's calcaneus and their Achilles tendon staying in alignment? Is there hyperpronation? Do they have a crossover gait? Do you see what's happening on this patient's left side? That his left side tends to cross over a lot more than his right side, that he's getting some bowing of that Achilles tendon on the left side, whereas the right side looks fairly decent. He's not perfect on either side, but there's a lot of crossover happening here and some bowing. So this is a way just to slow things down and then give an example to the patient that it's unlikely I'll solve your Achilles tendinopathy from that stretch that's happening. It's unlikely I'll solve your plantar fasciitis unless we do something to change your gait, which means a wider gait and a little shorter gait, and do something to strengthen that piece of duct tape and bungee cord that hold up your arch, the posterior tibialis tendon. So we want to assess that posterior tibialis tendon because that is what helps to support the arch. And anytime the arch falls repeatedly, that tendon is stretched repeatedly. And a stretched muscle and tendon turn into a, weak muscle and tendon. So we're going to assess that. A lot of times there's tenderness just behind the posterior tibialis, behind the medial malleolus. So we'll see, does that hurt? We'll also assess the plantar flexors, because in most problems of the lower chain, we have tightness in the gastroc and soleus. We've played this video before, so we're looking at what are the trigger points within the gastroc and soleus. And as you might guess, we'll look for hip abductor weakness assessment. Or we'll look for hip abductor weakness by assessing a single leg squat. What happens when that patient squats? Then we'll work out the muscles that are tight. We're going to work out the gastroc and soleus. We're going to work out the posterior tibialis muscle. And so that muscle, remember, that's that bungee cord that runs along the medial malleolus up onto the tibia. We'll strip out trigger points that have developed in that muscle. And one of the things that's particularly useful is mobilization or manipulation of the ankle. That a lot of times when there's this chronic hyperpronation, that causes joint irritation, swelling, stickiness, and stuck. So a lot of times the talus becomes restricted. And one simple way to mobilize the talus is to take that patient's foot and gently axial traction their ankle. So right now this therapist is using her fingers, her pinky fingers, to contact that joint. I like to put my the middle fingers at that joint and then axially distract and apply a gentle thrust. And a lot of times we'll get an audible release of that joint as long as there's no contraindication to manipulation, but a simple mobilization for that. And we'll also probably need to get some orthotics to make sure that we're getting the support that that patient needs. That if that support is inadequate and the arch continues to fall in spite of our best efforts to raise it, then they may need something. Now, I'll almost always start with an active approach, that I want to teach the patient to strengthen their own posterior tibialis so that they don't need orthotics long term. Sometimes we can get by with arch supports and strengthening. If that's inadequate and then we need to put arch supports in, we will. But I'd never put a patient in a lumbar belt the rest of their life because they needed core stability. So why would I put them in an orthotic the rest of their life if they can accomplish this on their own? We'll start with an active approach and then default to the orthotics. And everybody has a different thought process on that, but I like to empower the patient to give them the ability to be participants in their own recovery and understand that recovery is rarely a passive process. Recovery is an active process, and that's true of foot hyperpronation as well. One of the things that I've found useful for managing hyperpronation and a lot of the disorders associated with hyperpronation, especially plantar fasciitis, is this. It's a tensoplast wrap. So tensoplast wrap means that you have two pieces of tape. So you'll get like 3-inch tensoplast tape and cut about a foot-long strip of it. And I'll take the first strip and wrap it inside out, so sticky side out around the foot. And then I'll put a little heel pad. And that heel pad, you'll see all of this video in just a second. That heel pad is about this size, about a horseshoe-shaped felt pad. And we're going to put that right underneath the arch. And in the video, it's going to be a pink pad that goes on there. And then we're going to wrap over the top of that with the second piece of tape. So now the patient has this sleeve that they can slip on and off to help provide a little bit of extra arch support. I find it particularly helpful to give it to them to wear at nighttime. So many of my patients who have hyperpronation-related disorders like plantar fasciitis have problems at night, and they wake up in the morning and stand up and ouch, there's the pain. They often don't like wearing a boot, and they don't like a Strasbourg sock a whole lot more usually. If we don't have to use those, then what we'll do is put that patient in a tensoplast wrap. And here's how that works. Let's play the video. So the way the tensoplast wrap works is we're going to cut those two pieces of tape for the patient. We're going to take the first piece of tape and we're going to wrap it around the outside of the foot, sticky side out. So Dr. Steele's taking this tape and he's wrapping it around the foot, back on the tape back onto itself. And you want that to be as neat as possible. You'd like it to overlap perfectly, if at all possible, without that wrinkle. It's so hard to train him to do a good job, but I'll keep working at it. He just put the pad on the undersurface of the patient's foot to help support the arch. Now he's taking the second piece of tape, wrapping that over the top, and then providing a little bit of an upward lift. And then the last thing that I'll do is I'll usually take a Sharpie and draw a line and an arrow toward the patient's big toe so that when they pull it off, they know how to slip it back on right away. After a day or so, it's kind of molded into position and you can just see it, but the Sharpie helps that process. The other thing that you can do, if you expect that that patient's going to need that type of support longer term, but maybe they don't have room in their shoe for an orthotic, so this could be a soccer player or a wrestler, somebody who just couldn't stick an orthotic in their shoe, we can put that patient into a PSC Fabrifoam wrap. So these are commercially available. They're about 30 bucks, I think, on Amazon, and you can put that PSC Fabrifoam wrap in there. And then we're going to give that patient some exercises. Like I said, we don't want to rely on these passive devices. A lot of times they are necessary, but if at all possible, we're going to make that patient an active participant in their recovery. So an exercise like a single leg stance, simply having that patient stand up on one leg. And when they're standing up on one leg, they're engaging those muscles of their foot. We can even have them lean forward a little bit and come back, and lean forward and come back. If you do that, you'll feel how much those muscles engage. Let's do a quick demo right here. Unless, of course, you're imbalanced or have a tendency to superviters, then don't do this demo at home. But if you do have the ability to stand up, let's do a quick demo here. Stand up on one leg and feel, does it take a little bit of contraction of those foot? Imagine that your foot is really stuck to the floor, that you don't want it to move much. And so what you're getting there is the engagement. Now, lean just a little bit forward and see what happens. And you'll start feeling your calf, you'll start feeling the muscles of your foot, stabilizing your foot and teaching them to engage. In fact, a lot of things that we teach depends upon the foot upward. Let me give you one more example here that I love this one, that if you have a patient who's pregnant and they're always talking about back pain and hip pain and leg pain, the way that we can help their spouse understand that is to have the spouse stand up and lean 3 inches forward. Go ahead and do that right now. Stand up, lean 3 inches forward. Feel what's happening to your foot. Do you feel those muscles engaging, your toes going into the floor? If you stand there for a period of time, you'll feel your hips and buttocks start to tighten. That's what's happening with pregnancy. So I understand is that because of the change in center of mass, typically someone will lean forward about 3 inches, or the equivalent of leaning forward 3 inches during pregnancy. So we're causing that natural process of engaging the feet. So a single leg stance is a great way to engage those muscles. Another really good way to do that is what we talked about, the leaning forward portion of that, which is valaise. Standing and leaning, touching your nose on a wall, coming back to neutral. Standing and leaning forward, touching your nose on the wall. Now, make sure the patient's not so far from the wall that they fall into the wall, but they'll gradually move that back just a couple of inches. It doesn't take much, as you noticed in that example. 3 inches of a forward lean causes a lot of engagement of the feet. We'll also make sure the patient knows how to stretch out their gastroc and soleus so that those muscles are staying limber. Remember, the gastroc is stretched with the knee straight and the soleus is stretched with the knee bent. We'll do some posterior tibialis strengthening. You've seen this exercise with a piece of rubber tubing, bringing that patient's foot up into hyperpronation. Bringing that patient's foot into internal rotation so that we're looking at the bottom of the foot and then dropping back down. Coming back up to look at the bottom of the foot and then dropping back down. And finally, teaching that patient what to do at home. That they are consistently wearing shoes that have good arch supports in them. That includes time at the house as well. So if they're walking around the house and they have a hyperpronation related disorder, they should always have something on, maybe even Crocs. Now don't wear them outside the house, but in the house that would be something that would be reasonable to help support that arch. They should minimize their time going bare feet. So we see a lot of these problems in the summertime after a patient has been barefoot and they've warmed up, and now they start seeing problems like cumulative trauma because their glass has overfilled because all summer long they were barefoot. Having too many pounds is an issue, and gradually escalating that activity at no more than a 10% increase in activity per week. So tarsal tunnel syndrome is very much one of those hyperpronation related disorders. Tarsal tunnel syndrome is the lower extremity cousin of carpal tunnel syndrome up top. Tarsal tunnel syndrome causes pain and numbness in the foot. So behind the medial malleolus into the heel and even the arch of the foot. Sometimes we can see some weakness associated with that, especially weakness of toe flexion. This picture kind of illustrates where we would expect to see the symptoms of tarsal tunnel syndrome, the numbness and tingling. In the hand, the diagnosis of numbness and tingling in the 3.5 digits is 77% sensitive for a diagnosis of carpal tunnel syndrome. And in the foot, numbness and tingling in the arch of the foot coming up toward the medial malleolus is again very sensitive for that diagnosis of tarsal tunnel syndrome, which typically affects here the yellow area, the medial plantar nerve area, and sometimes a little bit outside that zone. This is the anatomy that the posterior tibial nerve comes down through behind the medial malleolus, down underneath this flexor retinaculum, and then down onto the foot to supply the medial and lateral plantar nerves on the undersurface of the foot, the yellow area and the green area. So our patients with irritation to that, usually because of a hyperpronation disorder, are going to have numbness, tingling, paresthesia in that zone. A lot of times they'll describe it as burning, which is a little different from what we experience in the carpal tunnel. And I think that's because there's more prolonged stretch of the nerve in the tarsal tunnel. If there's hyperpronation, it's hard to get off of that unless you're off of your foot. So when you're standing for long periods of time, you're going to be continuing to stretch. So it goes from numbness and tingling into burning, right? The progression of that neuropathy. Whereas in the hand, most of the time we'll stop if we start to notice some symptoms and change positions. It's not a weight-bearing joint, so it's easier to move around. Like any neuropathy, these symptoms are worse at nighttime, and sometimes we'll have weakness of the foot itself, of the intrinsic muscles of the foot. One of the things that we'll recognize is that anytime someone has nighttime symptoms, that's kind of concerning. That we often think of bad things because infections and neoplasms tend to hurt more at nighttime. But neuropathies and tendinopathies also tend to hurt more at nighttime. So anything that is blood flow dependent, and a neuropathy is usually an ischemic process. Nerves don't like two things. They don't like compression, so think about Phelan's test, and they don't like traction or ischemic traction, think about reverse Phelan's test. The same is true in the tarsal tunnel and most any neuropathy. They don't like to be compressed, they don't like to be stretched. And at nighttime, we'll generally have a lack of blood supply, the blood isn't pumping as much, and many times we'll be in a position that creates that increased pressure or increased stretch, so those symptoms increase. The other condition that increases at nighttime is a tendinopathy, whether that be a rotator cuff tendinopathy, a medial epicondylopathy, lateral epicondylopathy, patellar tendinopathy, Achilles tendinopathy. Those conditions typically are degenerative in nature. They're not inflamed tendons, they are degenerated tendons. Remember when we talked about the gluteus medius tendon, it doesn't like compression, it doesn't like stretch. So they act very similar as far as the provocative factors and with this worse at nighttime pain. So we never want to write off nighttime pain, but we can expect that tendinopathies and neuropathies would present with nighttime symptoms. Most of the time, or many times, we'll see a heel pain triad where the combination of plantar fasciitis, posterior tibial tendinopathy, and tarsal tunnel syndrome all live together because they share a common etiology of the hyperpronation of the foot. So all three of those tissues are paying a price in that. How do we assess that? Well, number one, we'll say, is that underlying source, hyperpronation cluster, present? Does that patient have excessive forefoot abduction where we see too many toes? Is there calcaneal eversion, meaning there's a bow in the calcaneal tendon? Is there a loss of the longitudinal arch, especially when we have the patient walk down the hall? And is there navicular drop? So navicular drop can be objectively measured by having that patient stand with their foot on the floor but not weight bearing, take an index card and put a dot on their navicular, put the index card on the floor and put the dot on the index card next to the navicular, have them bear weight and see how far does that drop down. And that shouldn't drop down more than about 7 millimeters. If it does, then that's hyperpronation. Now, I've never objectively measured that in the clinic, but it is a way that if we want to objectify what's happening with our treatment, is teaching this patient how to strengthen their posterior tibialis having an effect, it would be a way to objectify that. But most of the time, patients are more interested in how they feel as opposed to the objectification of that. One of the other tests that can be helpful in any neuropathy is bang on it. So taking our reflex hammer and tapping it, saying, is that nerve irritable? Do we have any numbness or tingling shooting into the foot? But tarsal tunnel syndrome has a unique test that's helpful. In fact, two unique tests that are helpful. The second builds upon the first, so they're almost the same test. The first one is this dorsiflexion eversion test, which is, as it sounds, we're going to take that patient's foot into dorsiflexion and then evert it. We're going to hold that for about 15 seconds. So this is the neutral position that Dr. Steele's in right now. And what he would do is dorsiflex the foot, bring the toes toward the shin, and then evert their foot a little bit, bring their little toe out towards their fibula. And by doing that dorsiflexion and eversion, he's stretching the posterior tibial nerve behind the medial malleolus and seeing, is there numbness or tingling? This test will give us a better picture. It's called the triple compression test, which involves the first two, dorsiflexion and eversion, plus some pressure. So in addition to now taking this patient's foot into dorsiflexion and eversion, he's going to put some pressure on that area. So this foot is being held in plantar flexion by the examiner first, but what should be happening is applying, the second part of that test, applying some dorsiflexion and eversion and applying pressure. So we're giving it three sources of compression. We're giving it a ischemic stretch, and we're giving it a compressive force. And if there's no increase in numbness or tingling in the foot, a plantar fascia would typically not be irritated by that test, but a tarsal tunnel syndrome certainly would. One of the most sensitive indicators for a neurologic loss, a neuropathy, is two-point discrimination. So loss of two-point discrimination on the plantar surface of the foot is another indication that maybe there's some tarsal tunnel, because a lot of our patients will suffer from coexistent complaints that yes, they have some plantar fasciitis. When I touch over the inferior aspect of the calcaneus, it's tender, but maybe they have a coexistent tarsal tunnel. Remember, the shared common etiology makes either one possible. It's certainly possible that both glasses overflowed, or even more than both, the third glass of the posterior tibial tendinopathy too. So we want to rule out which of those do we need to assess, because some of the treatment approaches will be tweaked based upon what we're seeing in this patient's case. So loss of two-point discrimination in our plantar fasciitis patient gives us a suspicion that maybe there's something else going on. One of the things that we can do is IASTM of the posterior tibialis tendon. Again, here's the picture, the illustration of that tendon moving right behind the ankle. And so we can take our factor instrument or our Graston instrument and scrape longitudinally. We want to be careful because that's where the posterior tibial nerve lives as well. So any sensations of sharper discomfort or numbness or tingling with that we need to avoid. But we'll want to make sure we're releasing any sites of irritation between the posterior tibial tendon, the nerve, and the surrounding tissue. We can also do a nerve release at the posterior tibial nerve. So the way that this nerve release works is we're going to take, you can see the nerve drawn in green here. We're going to take that patient's foot into dorsiflexion as we take our thumb from very near where it is right now on that posterior tibial nerve and run it upwards towards the calf. So we're dorsiflexing the ankle at the same time we're running our thumb along the course of that nerve. We'll also work out the posterior tibialis. That is that piece of duct tape or bungee cord that helps to support the longitudinal arch of the foot. So it develops trigger points most of the time proximally closer to the knee. So we'll work that tendon, and then we'll teach that patient what to do at home. And that includes what we've talked about before: stretching out the gastroc, stretching out the soleus with their foot propped up on a desk or a curb or a ball or a book, and working the posterior tibial nerve. So a posterior tibial nerve floss looks like this, that we have that patient flex their knee and dorsiflex their ankle with a towel wrapped around it, and then lengthen both. So go as long as you can, now as short as you can. So move your big toe away from you as far as you can, relax the tension on the towel, and now bring your big toe as close to you as you can while you're lying on your back. So that's a nerve flossing maneuver. We talk a lot about nerve tension tests and nerve flossing tests, especially in the last decade. That's picked up dramatically. And there are some experts in that field. We're not the experts in the field, but we absolutely use nerve tension tests and nerve flossing tests. That in the lower extremity, all of us use a nerve tension test called the straight leg raise. In the upper extremity, not as many of us use those nerve tension tests as far as the median nerve tension test, the radial nerve tension test, and an ulnar nerve tension test. But when a tension test is positive, it means when I put tension on that nerve, there's irritability. Well, a lot of times what that is the nerve has become inflamed. And when a nerve is inflamed, even at the nerve root, the entire nerve will be inflamed, which means it's a little or irritated and swollen. And when it's swollen, there's an increased hydrostatic pressure within that nerve compared to the tissue around it, which means tissue is probably going to start weeping, gradually, but weeping fluid. When it weeps that exudate, it's going to then become sticky, and that exudate forms these fibrous bonds or spot welds along the course of the nerve. So if we have spot welds along the course of our sciatic nerve, or a spot weld down at the tibial nerve behind the medial malleolus because of that chronic inflammation, now when I stretch my foot, it's going to create a traction ischemia because a nerve needs to stretch and glide. A nerve is not like a piece of copper wire. It's nothing like what we saw in the cadavers that we worked on. It's more like a bungee cord that has to move in an oiled tube. And if it's not able to move in that tube, or if something's trapping it, like some fibrous adhesions, and then we stretch the distance of it, we're losing all the benefit of being able to stretch the top portion. So all those spot welds are areas of ischemia anytime that we then move the tissue. So nerve flossing aims to help break up those areas of ischemia. A nerve tension test is like taking a shoestring and pulling both ends of it. We're going to stretch it. But that shoestring lives in a canal in the body. And that canal is not necessarily formal, but all the tissues around it form that canal. So imagine a shoestring and a straw. And if we dump some weak Elmer's glue into that straw, and now we had a spot weld in there, which happens from the swollen nerve exudating and then becoming adhered. Now, when we tension that, the nerve's irritable, it's going to scream at us. So if we want to break up that adhesion, the way that we would do that is pull on one end while we release the other, and then pull on the other end while we release the other. So pulling that back and forth in that canal is what's going to help break up those adhesions. So this is the process of breaking up those adhesions or getting the nerve to glide, to increase the neurodynamics of the posterior tibial nerve at the ankle. We know this is very successful in carpal tunnel cases. There's not as much research for tarsal tunnel, but yes, it's successful there as well. The other thing that's successful is strengthening the muscle that allowed this that contributed to the fallen arch in the first place. So strengthening our posterior tibialis muscle, having that patient put the band on their feet and looking at their foot as they roll it upward. So our clinical pearls for tarsal tunnel syndrome is a lot of times it's misdiagnosed. It looks a lot like plantar fasciitis because it goes into the same area. Hyperpronation causes that problem. That stretches the nerve. It causes chronic irritation, and most of the time, or a lot of the time, that pain is worse at nighttime, like most any neuropathy. Anytime we diagnose any one of these problems, whether it be hyperpronation, tarsal tunnel syndrome, posterior tibia tendinopathy, or plantar fasciitis, we want to look for its neighbors. And we'll talk about that last neighbor in just a second.